finding. We find the more red meat, processed meat, dairy, refined grains, processed breads and things like that, desserts and sweets, well water, and pesticides that people are exposed to, the higher the risk of Parkinson's. Among people who eat diets high in fresh fruits, fresh vegetables, beans, fish, coffee, and tea, they have decreased risk of Parkinson's. So it's association. It might be other things. It might be that people who exercise are more likely to eat a plant-based diet. It has nothing to do with the diet. It's just the healthy people are less likely to get Parkinson's. We don't know what's cause and what's effect. But I think that this data is compelling, especially when the same results are coming up over and over and over. I believe we have now had 6 studies that say the more dairy you eat, the more likely you are to get Parkinson's. And I'll present our own data that says once diagnosed, the more dairy you eat, the faster it progresses. So my point is every one of you who has children, every adult in here who does not have a diagnosis of Parkinson's, why in the world would you not be eating the foods as much as possible that are associated with the decreased risk and trying your best to avoid the stuff associated with increased risk? It just seems a sane, simple, safe attempt at decreasing risk. So traditional epidemiology is the study of who gets disease. My area of research is what happens from the point of diagnosis forward. The field is called clinical epidemiology. It's been a very emerging field in the last decade or so, and it's never been applied to Parkinson's until now. And we know a lot about cardiovascular disease. It's true in cancer. There's a lot of research. But nobody has taken a group of people with Parkinson's disease and asked, we know there's a tremendous amount of diversity. Some people progress really fast, some people progress really slow. Nobody has surveyed a couple thousand people with Parkinson's to figure out what are the lifestyle things that you're doing, the pills you're taking, supplements and pharmaceuticals, the types of exercise. What are you doing? Is there something that the fast progressors are doing differently than the slow progressors? And that's kind of the basis of most of the research that I'm doing that I'll present here today. And I don't know what causes what, but we are very clearly seeing that there are huge differences between fast and slow progressors. So before I get into the labs, my PhD work is in glutathione deficiency. I just want to use this as an example of kind of the stuff I'm talking about. It was 1982, the first time a paper was published called Parkinson's disease, a disorder due to nitroglutathione deficiency. What these researchers did was they did autopsies on people with Parkinson's disease and found out people with Parkinson's had a brain glutathione level that was 40% deficient compared to age-matched controls. So we all decrease with age. And a 60-year-old is about 30% deficient compared to a 20-year-old. So with age, we all get lower in glutathione, which is one of the reasons why this might be an age-related disease. So as glutathione levels decrease, glutathione is the body's primary antioxidant, and what it, even more than its role as an antioxidant, what it does is it's a detox nutrient. It's kind of, if you think of your cells have this process happening and they make waste, glutathione kind of helps wring out the dirty sponge. A few years ago, when my daughter was about 8, she asked me what caused Parkinson's, and I was trying to explain protein aggregation and impaired autophagy. And she very wisely said, "You mean their brains are constipated?" And that is exactly what's happening. We cannot clear the misfolded protein. We cannot clear the waste. There is a problem taking out the trash. And so one of the major roles of glutathione inside each cell is cellular detoxification. That's one of the ways that your body handles waste in your cells. So I took an interest in glutathione. What's fascinating about it is glutathione deficiency comes before mitochondrial dysfunction, before you start getting dopamine depletion, and before you start losing dopaminergic neurons. We have been trying to give people glutathione for the last 20 years or so. And so what I've done with my research is, first of all, we wanted to know, the goal is to get it to the brain, right? And so I thought, logically, snorting it would be the easiest way to do that. And so I started working my work on intranasal glutathione. I actually stole the idea from some ear, nose, and throat doctors in Seattle. We're using intranasal glutathione for people who have chronic sinusitis. And so because people were already spraying it up their sinuses, I just thought I'd have my patients sniff a little bit harder and try and get it to their brain. And Michael J. Fox Foundation funded this research where we put 15 people with Parkinson's disease in the MRI. We can now measure brain levels of glutathione with technology called spectroscopy, non-invasive. It takes about 45 minutes. And we put people with Parkinson's in the MRI machine, and we got a baseline scan, and I slipped them in a little syringe full of glutathione with a mister to the top, and they laid there and administered glutathione. And what we saw is over the next 45 minutes, there was a 240% increase in people's brain level of glutathione. So most, like 90+% of new neurological drugs fail because the drug does not reach target tissue. We can't get it to the brain. So this is a major hurdle jumped. Just to be able to see that you can spray a little bit of this saline-based medicine up your nose and have it reach the brain was a big win in terms of delivery of glutathione to the brain. This is just a quick summary of the trials. This was done by some Italian researchers in 1996. This was an old school accelerometer. This is the person's tremor before any medicine. This is after IV glutathione twice a day for a month. This is during the washout period, and this is on 25/100 carbidopa-levodopa 3 times a day. So there's a huge placebo component. This was not a placebo-controlled trial. I don't necessarily trust these results. If I had a nurse coming and giving me attention twice a day and giving me an IV and talking to me, you would expect better outcomes than just popping a pill. There's a whole body of research that says the more attention you get, the more invasive the intervention, the better the placebo response. And this seems to be especially relevant to people with Parkinson's because the placebo response is based in dopamine. When you feel hopeful, when you feel excited, when somebody's giving you attention, when you feel good, you make more dopamine. And guess what? That treats your symptoms. So people with Parkinson's are unusually responsive to dopamine, the placebo response. So, but even though I don't think this is terribly great quality data, we should follow up on it, right? And so in Florida a couple of years ago, there was a study where they did a double-blind placebo-controlled pilot study. It was not powered to answer the question, does it work? They just wanted to know, is it safe and is it tolerable? So what they did is they had half the group use glutathione, half the group use placebo. The authors concluded it is safe, it was tolerable, and we saw a little teeny improvement in motor symptoms in the group that got glutathione that got a little bit worse after they stopped. Again, the goal here was not to answer the question, does it work? We just wanted to know, is there something here that we might want to follow up on? So then my research studies came along and we did double-blind placebo-controlled trials of placebo, low-dose and high-dose glutathione. This is the improvement in UPDRS, you know, that outcome measure that your docs do with you. This was the improvement in UPDRS among the glutathione group and the placebo group. And Fox Foundation said, really, it's too good to be true. Glutathione shouldn't do anything for motor symptoms. We would expect it might slow progression, but we weren't really expecting it to treat the motor symptoms. So can you just repeat that whole study again? And let's just see if it was a fluke. And so the goal was, will we get that same 4 to 5 point improvement in motor symptoms with another study the same way? Well, the problem we ran into is, yeah, we got the same 4 to 5 point improvement, but there was so much community enthusiasm. We had 70 people we turned away from this study. People were so excited to be a part of it. So there was a huge community placebo response, and the problem we ran into is not only did we get the results we were hoping to get with the active arm, this time the placebo arm also got a 4 to 5 point improvement. And so I had to conclude in the paper, glutathione is not superior to placebo, but it's not because it didn't work, it's because placebo worked so well. So we're a little stuck there, but this is just another paper we published showing that the lower your glutathione levels, the worse your Parkinson's symptoms. It's going to come up as a question, so I'll just tell you now. People want to know, why didn't we measure my glutathione in today's labs? The test is available. I think it's $300, $350. And you get fresh fruits and vegetables are a major source of glutathione. No matter what your glutathione is, I'm going to tell you to eat foods that are high in glutathione. And there's no result you would get that would change my recommendation. And so I did not think it was worth the money. So that brings us to the nutritional deficiencies that many of you had done. I would say about half of you had labs tested. So the way I think about this is, Parkinson's is this boat that's got a bunch of cracks in the bottom of the boat. And I consider the dopaminergic meds, anybody who works with me knows I am a huge advocate for dopamine replacement. I think it is silly to continue to deprive your body of dopamine. We all agree you don't have enough, you can't make enough, you're not starting to have the symptoms. By the time you get a diagnosis of Parkinson's, you've already lost 50 to 70% of your dopamine producing neurons in the brain. You are getting to this late. I do not think you do yourself any favors to play the game. How long can I continue to deprive my brain before I give it what it needs? Right? It's just not helpful. So anybody who knows me knows that while I'm working really diligently to try and find the holes in the bottom of the boat and plug them up, I also think it is in your best interest to use the dopaminergic meds like a bucket that can lighten your load. So this is the more comprehensive panel that we do at Parkinson's Summer School. There are some reasons we didn't do all of that. One, cost. We didn't have the time to interpret it. But I don't want anyone here thinking this is everything I ever test for. I think it's really important to do these individually. So what we did today are the things that are the blood and the urine, one of the tests in the urine. And so we'll kind of talk about what that is. About labs, before I get into this, I want to say, if so, so what? Just because you can test for it doesn't mean you should. And just because your other docs in the conventional community is not testing for it does not mean that you shouldn't. Before we order a test, we should consider the consequences. How much does it cost? What are you going to do with the data? And most importantly, don't order a test if it's not going to change your course of action or change what you're doing. It's just a waste of money. The only tests I advocate doing are the ones that have been linked somehow or some way to Parkinson's disease and that we can modify, that you'll actually do something about. New York actually has a law that makes it a little harder than most places to do some labs. If we weren't in New York, I probably would have asked that you send in a hair sample to test for lithium status. But New York has rules that say if the lab is not based in New York, we can't use that lab. And so the lab that is doing the hair analysis for lithium, my master's work in epidemiology is in lithium deficiency and Parkinson's disease. I think it is a really, really important part of the initial workup that I do with patients, but because we are in New York, that wasn't an option for today. So the other thing I'll say before we get into reference ranges, every single person who had labs done, I took a red pen to it, I made my notes, and some of them you will see that I changed the reference ranges. Reference ranges change over time. Homocysteine levels higher than 15 used to be called problematic. Now anything above an 11 is called problematic. And research in Parkinson's says it might be even lower than that. I think a really good example of this is the omega-3 fatty acid profile. One lab recently bought out another, and they made this decision to change from the reference range used to be, what does healthy look like? Among people who get the least cancer, the least heart disease, the least Alzheimer's, what does their profile look like of omega-3 fatty acids and inflammatory fatty acids like arachidonic acid? And for the last 7 years or so that I've been using the lab, that's the reference range. What is compared to what is healthy? Well, the lab just got bought out and they changed the reference ranges and they're no longer what is healthy, it is what is average in the United States of America. And let me tell you, there's a big difference between what is healthy and what is typical. So I have gone through and noted where I think it's important to have a slightly different reference range than what the lab may have on the printout. So stages of nutritional deficiencies come in multiple stages, right? And so stage 1 is when you have no symptoms, Physiological function is continuing normally, but your stores are starting to become depleted, right? Stage 2 is you can measure things in biochemistry. You might be more inflamed, you might be able to see high homocysteine levels as a marker of B vitamin deficiency, but you still don't have clinical symptoms. In a stage 3 nutritional deficiency, you now have clinical symptoms. So what I'm trying to do is screen for folks who are at stage 2, hopefully before you got to stage 3. Many of you might already have some stage 3 deficiency symptoms, but this is kind of how the rules work. Supplements have side effects. A friend of mine just sent me this picture last week. He took B vitamins, and this is what his tongue looks like. I wanted to know if this was a problem. So side effects come in a lot of different shapes and forms, and I want to include cost as a side effect. These things can add up. A lot of people are on fixed incomes, and I always joke, if people came to my office and said, and I have had people fly to my office and say, money is no issue, if there's any chance it might slow, stop, reverse Parkinson's, I want it. It would be so easy to send that person home with 3,000 supplements. And we have to use our heads here. We have to pick and choose our battles. And so, and it's also an energetic side effect of this goose chase, right? It is time intensive to have a pill case of 37 different pills, and oh, is this one going to work? And now I'm on this. And so I just want to say, I tend to, even though, you know, I recommend way more supplements than most of your other doctors, I do think my approach is fairly conservative. In general, I say there are 2 sets of supplements I'll recommend for people. The ones that our research shows are associated with slower rates of progression. There are 4 of them. I'll talk about them in a minute. And the ones that your lab tests tell me that you need individually. After that, if you want to take more, go for it. I'll tell you if it's going to interact with your other meds, or if it might be a safety concern. If I think you're wasting your money, I'll let you know that. But a lot of my patients take a lot of things that I don't recommend, and that's okay. But my recommendations come from 2 columns. My data says it is associated with better outcomes over time, and you have some sort of biochemical evidence on my assessment tools that lead me to believe you're deficient. And it's not just blood work. I mean, there's a nutritional physical exam. I mean, we should be looking for white spots in your nails to look for zinc deficiency. We should be looking for rings around your eyes for Kaiser-Fleischer rings to look at copper levels. We should be looking at skin, bumps on your skin for vitamin A. I mean, that's what we're taught to do in medical school, and myself included, don't do it as much as we should. It is not something we're doing as much as we should. You can look up the symptoms of nutritional deficiencies, and here are all the clinical manifestations, but physicians tend not to work backwards. They don't see a person with a red tongue and like, oh, let me measure your B12, right? They would just beef your red tongue. So everything that is on the Parkinson's panel that I do in my office has been somehow linked to Parkinson's outcomes, or the symptoms of low thyroid can look a lot like Parkinson's disease, and I think it's important to rule out. And everything on this panel is modifiable. The cost of this panel varies dramatically. If you pay for it out-of-pocket cash up front, you can get it for $300. If we bill your insurance, you will see a bill for often well over $1,700. And so it really depends on the state you're in, the provider that orders it, whether you've made your deductible, things like that. So I'll start with homocysteine. I think this is one of the most important ones. I know you can't read this as well as I'd like you to, but basically homocysteine is something we all have, and the higher it is, higher levels have been associated with more rapid Parkinson's disease progression and a pretty notable increased risk of dementia. And there are 2 reasons for that. One is because the reason homocysteine levels go up in the first place is because you are deficient in either folic acid, B12, B6, or something called betaine, trimethylglycine, very high in beets, by the way. So what we want to do is find out, are you high in homocysteine? Because all you have to do is supplement these things. It costs about $15, $17 a month. You take a product that has all of these in it, and you can lower your homocysteine, right? So not only do B12 and folic acid deficiency on their own contribute to dementia. But homocysteine levels, once they go above 15, 16 or so, homocysteine molecule itself becomes a